We're going to be talking about place-based policies, and this first session is on place-based health strategies. And we have a terrific panel here. I'm going to do fairly brief introductions of the members of the panel and then let them have the time. And as Ben indicated, everyone's bios are on the website if you want to know more. So, and we've had an addition to the program, Mayor Urban of Aurora, who many of you heard speak last night, is going to talk about Aurora and what it's doing for place-based health, and sort of actually kick off the session. In addition to Mayor Urban, we have Larry Morrissey, who served the city of Rockford, Illinois, as mayor for 12 years, and is now vice president at Marathon Health. We have two other distinguished vice presidents of Marathon Health. Sasha Loffredo is a physician and the VP of Medical Services at Marathon Health, and Michelle Rosowsky,
pretty good, yeah.
Okay, is the VP of Business Strategy at Marathon Health. And we're going to see what they're doing. Marathon Health is a large national insurer, I think in 40 states, I read.
We provide clinical care for employers, so
Okay.
not insurance, but we're 42 states.
Oh, 42 states. Okay. Well, why don't I let the folks from Marathon Health describe what Marathon Health does.
Great.
But first, let me give it to Mayor Urban.
So the way we're going to do it is I'm actually going to get us started, and I'll be doing some interaction at the front. So I'm a recovering mayor, and what you'll find is that mayors, just like last night, we're not bashful about speaking. I was actually, during last night's presentation, who all was there last night? Let's give it up for Mayor Urban and the great job that he did. And I was thinking as I was in the audience, you know, keeping my mouth shut, God, I kind of wish I was on stage. This looks like it's a lot of fun, great conversation. And then tweets started popping up on my Twitter stream from the City of Rockford City Council meeting. And it was crazy, and I knew all the players, and they were, you know, doing what they normally do. And I said, I'm in the right spot. 12 years was plenty, but it was an honor to serve as mayor of the City of Rockford. And really, I'm going to be jumping directly into our conversation about place-based health. I just want to start by getting a sense of the audience, and I'm going to be doing some interaction back and forth with Mayor Urban as I do this. But as I jump into the topic, let me just go through these quick set of goals that we want to go through. Number one, by the end of this, we want all of us to have discussed and considered whether and how place-based health applies to your organization. By the way, out of the folks in this room, who works directly for city, county, or other local governments? So quite a few folks. How about folks who are in nonprofit sector supporting? All right, how about others who are, what kind of stuff are you all doing? Research? Universities?
Yeah.
Who, outside of universities, anybody? Yes? Think tank. All right, good stuff. Oh, research. So for all of us in this room, I think can consider us all colleagues. The reason why you're in this room might be because you already get it, but I can tell you when I was first elected, nobody told me I was going to be running a healthcare organization. 12 years later, I would tell you that's exactly what I was doing. So we also want to identify and consider opportunities to drive place-based health solutions as an employer. This is what we do at Marathon Health. We help both public sector and private sector employers take ownership and responsibility of their own employees and their dependents and families and try to improve health using population health principles and clinical care. Also want to consider clinical interventions based on social and place-based determinants of health. And then we'll consider opportunities to drive place-based preventive care solutions that leverage operations like city police, fire, even public works, social services, etc. into your organization. And finally, we'll describe and discuss emerging payment models for funding your organization's prevention-based health solutions. So first on this consideration of place-based health, for those who are in city government, how many of you today would consider yourselves, let me ask you this, how many of you think your city councils and your leadership at the city considers itself a healthcare organization? Anyone? Mayor, you and I talked a little bit about it.
You know, I don't know that they consider themselves a healthcare organization, but the reality is that's the whole reason that it should be the whole reason that we all are in office, you know, as mayor of a city, you know, it's important to make sure that we bring all our city's functions together to take care of our citizens in the community. So when I think about place-based health, I think about not just clinical or individual physical health. I think about health of the community as a whole. Social services that brings health to the community. You know, just the community at large being a functioning community, which would be workforce development, jobs, economic development, you know, make sure our police and our fire keep our community safe. This all lends to the health of a community. You know, for example, if you have a child that's two children born in a city like Aurora, and in Aurora, it's actually a tale of three cities. We have a low-income area where 80% of our people live under our poverty level. Then we have a middle-income area. Then we have a high-income area. So let's say in our low-income area, we have you know, a gang problem, and we have a teenager, 14 years old, joins a gang. And then in our high-income area, we have a heroin problem, where, you know, our young kids, 14, 15-year-olds, are getting addicted to heroin. At 15 years old, both of these kids die. One dies from gang violence, gunshot. Another dies from a heroin overdose. You know, two totally different issues, but both that affect the health of a community, whether it be the epidemic of heroin or drugs, or whether it be gang violence. And we deal with these kind of things in a city, you know, the second largest city in the state of Illinois, rural Illinois, and these are the kind of things that we have to work to address. And when and the next thing, the step is what social services are available to make sure this child that might be addicted to heroin can get, so, you know, to address those addiction issues or prevent them from being addicted in the first place. Or what kind of social services exist to keep this young person out of a gang, so this person, you know, doesn't succumb to violence. All these kind of things are things that we deal with when we talk about dealing with health of a community. So my job, you know, is the leader of a healthcare organization, I believe, taking care of the community at large as mayor of the city.
Any great points, totally agree with them. Any folks who are familiar with one specific area of city operations, fire departments? Show of hands, how many people think their fire department is mostly putting out fires each and every day, right? So what are most of the fire calls in a typical urban operation involved with? Anybody know? Medical calls, right? Right. So in the city of Rockford, it was over 80% of our calls or thereabouts would be medically related calls. So when you think about it, literally, up until December 2015, all we could do with those calls would try to stabilize someone and bring them to the ER. But essentially, that's when I started to realize through our work with the fire department that we really were part of a healthcare organization. So this question we've already been getting into, our city challenges, health challenges. And by the way, we'll come back to these at the end. I'm just going to try to get through them early. It's just things to think about as we go through our material. Do you consider crime, education, jobs, economy, health issues, just like we heard from Mayor Irvin? Absolutely, he does. Where can healthcare be delivered today? This is one of the things our company, along with a number of folks who do our kind of work, realize the workplace is a great place to really be in the healthcare business, and that's what private and public employers are doing. They're hiring companies like us to bring primary care, preventive care, and chronic disease management into the workplace. Schools also. Anybody heard of the acronym ACEs? Anybody know what that means? Who wants to tell the group?
Adverse childhood experiences.
Right, so trauma-informed education is becoming much more prevalent. That's something in my private life now, my wife and I are very passionate about. Children who have suffered trauma, significant traumas at a very young age, tend to be the children who don't succeed in the traditional. We heard a lot this morning, some great comments about policy-driven attributes that make it hard for folks from different ethnic backgrounds, races, to be successful, and that's one of the things that I found out as mayor. You can't treat all kids the same when some kids show up to school having slept in a bathtub the night before because of gunshots in their neighborhood. So these are very real places where we see healthcare needing to be delivered today. Public health versus community health, population health versus clinical care. Is anybody familiar with, and I'll get to this next point, anybody participate in a community health survey? Under the Affordable Care Act, I believe it's every 3 years, healthcare organizations now have to do these community surveys. I came to call those the annual autopsy report as mayor, because so much of the data I would be thrown at me was just awful stuff, and it was not actionable because it was survey driven. So that's why I started to come into conflict. By the way, I have none of this, I'm not trained, I'm a recovering lawyer, right? So it allows me, I guess, to be an expert in a lot of things, but really not in anything. But what I found is that through those community health surveys, the data was being gathered typically on a survey basis. We'd use things like census data as opposed to clinical data that we use now in my current job and what we started to use at the city to do direct interventions. Anybody familiar with, so I already asked the question, is the survey a diagnostic report or an autopsy report? Is it interesting data or actionable data? Is your 911 data part of your community health data? Any show of hands, anybody whose 911 data is actually being included into their community health? Awesome if you are. Where are you from?
Buffalo, New York.
So yeah, we started to do that. Very few, I found, places that were actually doing that, taking 911 data and really looking at it as the pulse of your community. But I believe it absolutely is. If you want to find out who's sick and what's going on, check your 911 records. But integrating those into your public health snapshot, for me at least, was a huge challenge. And then finally, do you understand how our American care model differs from other parts of the world? And what we do in our country when we elevate sort of hospital care and clinical care from both sort of cultural standpoint, but also just as importantly, if not more importantly, from a payment standpoint, versus social work, versus the work of police officers, firefighters, those out in the community. Anybody know of any examples in the world that are different? So short answer is most places are different. Almost every place is different. That's why we typically wind up, in my belief, as the most expensive healthcare system globally when you look at per capita spend, and you look at countries like Cuba, which I'll talk to about a little bit later on, where they actually have better health outcomes with a lot less technology, a lot less spending. That's one of the other things we want to talk about today. Why are those differences there, and what might we do about it? Mayor, anything else that we missed that you want to comment on the front end?
No, I think you.
Otherwise, we'll come back at the end and pick up a number of these questions. So with that, let me turn the room over to Michelle. There's no real mic, I was going to say that, right? But turn the room back over to Michelle to take us through the next part of our discussion.
Larry joined our organization after he stopped being mayor, so I was worried watching you in there. I was afraid you were like kind of missing being a mayor and that we were at risk of losing you again, so I'm glad to hear you. We're happy with where you are. So yes, I work for Marathon Health, and since this is all about place, I thought I'd include a picture of Burlington, Vermont, which is where I live, and that's a restored mill called the Champlain Mill Building on the Winooski River, which is where Marathon Health's corporate offices are. So Marathon Health does population health management. We run on-site, I think Larry mentioned this, on-site or near-site health clinics at large employers for the employee populations. And we have customers all around the country. We provide acute care, preventive care, disease management, just recently added behavioral health, and all of it with a real focus on wellness and health coaching and really helping people feel empowered to manage their own health better and achieve their health goals. We have customers in almost every industry, and about a third of our customers are actually cities, counties, and public school districts. I saw Olathe and Chattanooga on our list. Is anybody from those two cities or counties in there? Where? Chattanooga? Okay, so Chattanooga is one of our customers, one of our valued partners. So essentially, we do place-based health, but place is the place of employment, the way we think of it. So I just wanted to run you through a little bit, and Larry will kind of come back to this later, about how we do population health management. We begin by identifying risks. So we mine claims data, we do biometric kind of preventive health screenings and do health questionnaires so that we can sort of get a sense of who's in our flock and what the risks are. So the first step really to population health management is to identify where the risks are, what kind of health risks we have, what the prevalence rates are. The second step is to mitigate those risks by engaging the people that are at high risk. So I heard an analogous situation was with crime, knowing which youth are at risk for committing crimes. We can tell from all this data who's at risk for having serious health complications or becoming a high-cost claimant to their employer. And we have a lot of different strategies for how we outreach to these people, but key is these patient lists. So our electronic medical record can actually output lists of the people that we need to reach out to. So now we're not talking about a forest, we're talking about trees. We know the individual heartbeats, the lives that need to be touched, and we kind of go about doing that one person at a time. And then that changes their utilization of the healthcare system by preventing more serious complications and hopefully making them better consumers of healthcare. And then naturally that leads to cost savings for the employer. Typically our customers are self-funded, so they're paying for healthcare costs. So not just by redirecting care to our health center, obviously preventing serious complications, and also we know that healthy employees cost less and have fewer missed work days and things like that. This is just what that journey looks like from a patient standpoint and some of the tools that we use to do population health. This is just a quick illustration. So using the example of an employee population of around 900, we've screened most of them. We mine claims data on some. That gives us an idea of where the risks are, and we pull that out, and that's our high and chronic population, high risk and chronic conditions. We call that our target population. Those are the people that we outreach to. It's not to say we don't touch the healthy people and try to reach those other people as well. And anyone coming into one of our health clinics, even with a sinus infection or whatever it is, will experience some appreciative inquiry and some talking about their health. So we do that across the board, but here's where we can have the greatest impact. So, our model really hinges on that patient-provider relationship. That's where the magic happens. And we provide access to this great healthcare. Employees love it. It's right there at work. It's convenient. But this is where it gets interesting for us, especially in the context of what we've been talking about here, why I'm so excited to be here. When a flower doesn't bloom, you don't necessarily just look at fixing the flower, right? You look at the environment. So in fact, we know that healthcare is actually a relatively small determinant of actual health outcomes in the long run. So this is a very sobering statement for us. As a determinant of overall health, healthcare plays a minor role. So this is sort of underscores the importance why we see it to be so important to really engage in community partnerships, help our customers who are employers, and a lot of them, of course, being cities and counties, to sort of focus on the community partnership piece of that. So you guys, I've heard there was a whole plenary session on this, which I missed, so I'm sure you guys already know the answer to this. Can anybody tell me? What are the most important numbers to determine your longevity and your future health status? Zip code, exactly. You've probably seen this from Robert Wood Johnson Foundation. This is the DC area and the change in life expectancy. And of course, what we're getting to here is economic segregation, which we've been talking about, that results in health inequities. So that brings us to social determinants of health. We're interested in this because everything I talked about with our risk stratification model was all based on clinical claims and lifestyle risks, right? But now there's all these other things about where people live that are critical for us to achieve this population health outcomes. So social determinants of health, I think a lot of you are involved in this already, so I'll just sort of touch on several of these. These are things that have a direct impact on our ability to achieve improvement in health outcomes for populations. Financial stability, education level, especially early childhood education, but like many of these, there's a gradient, so people that are a little bit educated tend to be a little better off health-wise. People who are very well educated tend to have much better health outcomes, so there's a gradient there. Physical environment, I'm sure this is very relevant to all of you, and we're not just talking about exposure to public safety we'll talk about too, but physical environment is the neighborhood. So this is obviously, we know pollution and environmental toxins can affect people's health too. But we talked about whether there's bike paths, whether children have safe place to play, whether you have access to places to exercise. And public safety going right along with that. Fear is a deterrent to self-care. So a lack of safety in the community can impair somebody's ability to achieve better health. And then feeling socially isolated or feeling disempowered or discriminated. And again, I know that you guys have spoken about this at length, so you're aware of just how much of a role social hierarchy plays in somebody's behavior and in our perspective in their ability to achieve better health. So all these factors relate to the distribution of wealth and resources. Again, this is something we've been talking about, which is why the work that we're doing at this conference is so important, not just to improve the health outcomes, but also healthcare costs. So in our world, it's for employers, but this is also based on communities or national costs. So we care about this because we're passionate about changing healthcare, but we also care about these social determinants of health because our employers care about it. They know that these social determinants of health are also affecting their employees' productivity, absenteeism, the turnover, and of course the cost of providing health insurance for their employees. Community issues are mirrored in the employee population. These are reasons why our customers care so much about these community health issues. The ability to have a healthy workforce, of course, dependent on a healthy community. The employers we work with are great about providing wellness programs and great benefits like our on-site health care, but ultimately employees go home to their communities and to their families, so these issues are still critical. The community health issues are still critical for them to have healthy employee populations. In many cases, some of the information that's publicly available, I know Larry calls these autopsies reports, but a lot of this information employers don't necessarily have about their employees. They can't be necessarily asking what their household income is or even education levels. Many of them don't know. So sometimes they actually value this community health data to help them understand their employees better. And I have a really great example of that on the next slide. And it helps them determine what resources are needed beyond just EAP, but how to strengthen some of the community resources where they work. And many of them are actively trying to support their community health goals, the private employers and of course the cities and counties. So the cities and counties are sort of leading the way by providing this health care for their employees. They're sort of leading by example in improving the health of the populations in the communities they serve in. We have a couple customers, well, one in particular that's a manufacturing firm that almost everywhere they have operations, they're the main employer in their town. And they said, you know, we like to give back and we would like to improve the communities in which we work. So, you know, if you can give us ideas of what some of the social determinants of health are that are where the most critical needs are, these are places that we could actually help strengthen some of those organizations. So a lot of organizations that are very interested in improving community health and committed to that mission.
If I could just stop you real quick.
Yeah.
That's also when I've been very privileged both when I was in the public sector and now in the private sector to see those employers. Could be big cities, sometimes even in smaller communities. Think of the one customer that Michelle's thinking about, where the private sector employer is a lot bigger than the local government.
Yeah,
and
yeah.
they really have the ability to take a somewhat paternalistic but supportive role because the health of their company depends on really the literal health of the rest of the community.
Yeah, exactly. So one of our really innovative customers is Lincoln Industries. This is in Lincoln, Nebraska. Is there anybody from Nebraska here or anywhere near there? And I share this with their permission. Greg Howe is our customer there. And they just, like 2 weeks ago, had a training called Place Matters for their supervisors and leadership team to better understand what's going on in the community and how that impacts employee performance, employee retention, and employee productivity. So they had a bunch of speakers, and what they did here was use some Place Matters community mapping project that Lincoln Industries had, where they had sort of blocked, they have several different maps around different social determinants of health: access to healthy food, places to exercise, prenatal care, mental health accessibility, tobacco use, longevity. And what Lincoln Industries did, the red dots here, is actually mapped where all their employees live. And they sort of overlaid that on these community mappings to better understand what the issues were that their employee populations were dealing with. So they were doing this to help their supervisors, you know, understand the employees better and how to maximize performance and productivity. And it's the same with our understanding what their health needs are and how to outreach to them, because again, what's underlying here, the access to food, all these other things, are arguably more important than some of their clinical background for us to improve the health of the population. So, great example from Lincoln Industries. I'm sure some of your communities have community health plans like this. I just like this image because I sort of see where it ties the work you're doing with the work we're doing. So on these lower levels, the work that you do to address physical, social, economic environment of your communities to achieve population health, all the way up to the one-on-one relationship, which is how we're trying to improve individual health. So these things are all tied together. We're more successful when there's community support, and community support only goes so far if you don't have that one-to-one relationship with the healthcare provider. So I just like the sort of tie there. And then lastly, Larry's going to talk a little bit more about performance-based funding. So I just wanted to touch on outcomes. You know, we measure the impact we're having at each of our customer sites, but it's also nice sometimes to step back, and annually we aggregate all our data and look at our book of business results across the board. And we use the Triple Aim, the Institute for Health Improvement's Triple Aim, which is patient experience, how we're doing on providing a better patient experience, how we're doing lowering healthcare costs, and we've saved, I think I came up with typically our model pays for itself within a year for these employers, and we achieve anywhere from like a 2-to-1 ROI, return on investment, within a couple of years. It goes all the way up to a 4-to-1 ratio. So for every dollar they're spending on our services, they're saving $4 in healthcare costs. So financial savings. And the third element of the Triple Aim is most important, people are getting healthier. So more people with chronic conditions are at the standard of care. More people are making progress on key health risks. So Sasha's going to take it next and just talk about what this looks like using an individual patient example and why these social determinants come into play in that one-to-one ratio. Does anybody have any questions on the stuff I covered? Yeah. Yeah.
Did they see a correlation of, I guess, pay or where the people are on the employment scale in correlation to where they live?
Like salary
So
bands?
yeah, so salary-wise.
That's very interesting. They just did this mapping project 2 weeks ago, so it's definitely a work in progress, and that might be a good question to ask him.
I guess cities or us can use to influence industries to raise their wages.
Yeah.
Talk about minimum wage.
Yeah, and
Conversations.
yeah, that would be very interesting, not just the salary bands by role, but salary bands by where they're actually living in the community.
So
that would be interesting.
Just as Dr. Loffredo steps up, I'll just give a punctuation, which I think ties into what you are just asking about and what we're seeing with companies like Lincoln Industries. To me, and also picking up from that last session we had over lunch, by the way, I thought they were going to pass out, drinks or something at some point. I was getting a little pessimistic and a little depressed during that talk about preemption. But it really, I'm telling you, as a local government guy, you get really frustrated when you're trying to make something happen and the state or federal government tells you not to do it. But the good news is around healthcare, what I experienced, what I saw, and I think what Mayor Urban seeing on his time early now on in Aurora is that we, working with companies like Lincoln Industries, can impact directly the healthcare ecosystem in a way that the federal government can't. The state government can't, they're just too far away. And Dr. Loffredo will get into actually some of the really literally blocking and tackling. What's this look like when it comes to individual clinical care, and what types of steps can we be thinking about doing as local governments to drive this conversation and really take leadership, where I think, how many know that the president did not sign the Paris Climate Accord, right? Mm-hmm. But what did state governments, some governors and cities start to do? They're gonna do it anyways. And so when we see the stalemate in Washington, what that kind of inspires me to think about is, well, why can't we take healthcare over as local governments and really drive these conversations with our local employers? So with that, Dr. Loffredo, there she is.
Here I am. So I'm a family doctor, but before I went to medical school and started my career, I actually got a master's in regional planning and spent 5 or 6 years working in planning in underserved areas and urban populations. and got really intimately attached to the health aspects of that planning and agree completely that everyone in any sort of leadership in city management, politics, the nonprofits, the think tanks that do this, you're all health workers. And I'm going to show you, when I'm a doctor and I see a patient and I'm trying to figure out what their health status is, when all of you go to your doctors or your primary care providers, they're talking to you about these things. What's your family history like? What's your blood pressure like? What's your cholesterol like? And that's great. Those are important contributors to your health status, but there's so much more. And Michelle's already showed this slide. And because the theme of this session is place-based, so many things on that list are related intimately to the place where somebody lives. So I'm going to talk to you about Miguel Garcia. And this is a patient, a real patient whose name and all the identifying details has been completely changed. So you would never be able to find Miguel. He's a 43-year-old. He's living in and works for a municipality, a medium-sized city in the southwest of this country. And so he's coming into the health and wellness center that Marathon operates for the city. And we take care of all of the city's employees and their families. And Miguel doesn't really speak much English. So is anybody from a city or municipality where there's a lot of foreign language primary speakers? So you might already know this, I'm not telling you anything new. Patients that don't speak English very well are more likely to have bad outcomes. So we know they're more likely to live in poverty and have less education, but they're also less likely to get preventive health care. And if we don't prevent something, it ends up costing more, not only in dollars, but in contributions that this citizen can make to his community. They're at more increased risk of health outcomes, and they're always less satisfied with their health interactions. So really important that the health systems in your communities recognize the populations and the languages they might speak. And it's one thing to have the federally qualified health centers that are taking care of a lot of the Medicaid populations, the uninsured populations. They're all usually equipped to deal with all these social determinants. But Miguel works for the city. He's got great insurance. He's probably going out to private medical practices because he can, and they're often the ones that aren't set up to manage this. Our electronic medical record flags when a patient doesn't speak English. We automatically assign more time because we have to use interpretation a lot of times. So those kinds of things can have an impact on this patient's health. So we're seeing him for his diabetes, and his numbers are wildly uncontrolled, and we don't have to get into what all these numbers mean, but his blood pressure and diabetes are not at a good state, and they haven't been. Every time he goes in and sees the provider increases the medicine or adds another medicine, and nothing changes. And like is common with these chronic conditions, he feels well. You don't feel sick when you have uncontrolled diabetes or high blood pressure until it's kind of too late. So what's going on? Well, in a standard medical encounter, what you typically experience when something's not going according to the initial plan is the provider thinks, do I need to order more tests? Did I miss something? Or maybe the provider's going to add yet another medicine or increase a dose of the medicine. And then, of course, like all good doctors do, they say, don't forget to take your medicines. It's really important. And that's great, but that's healthcare. And as Michelle pointed out, that's only 12% of a person's or community's health outcomes. So my role in that exam room is 12% of what's happening to Miguel Garcia. And that's might be a bruise to other people's egos. I got my ego bruised with that. But what is really important is behavior. There's a big chunk. And as you heard what Michelle described, our healthcare model really tries to get at the behaviors that impact people's health. And so for all of us, we know exercise is important. We know that eating a healthy, balanced diet is important. And we know that taking your medicines is important. Those are important behaviors that are all under Miguel's control. But what's at the root of these behaviors? And I'd argue that not only is behavior a big part, but what's really driving a lot of behaviors in most of our individuals in our communities is their socioeconomic status and the place in which they live and work. And for Miguel, he lives where he works, right? He works for the city. So let's look at exercise. Yes, I doubt there's anyone in the room that doesn't think that exercise is good for our health, right? We all should be exercising. But what are the things, so I can tell Miguel, you gotta be exercising, That's great. But there's so much here that people doing research, people in nonprofits out in the community, community leaders, the political community can address. Safe places to exercise. Are there community centers with exercise facilities? Are the streets safe to walk in after night? Miguel doesn't get home till after dark. Is his neighborhood safe? Are there sidewalks? What can he do to be able to exercise? And does he even understand what exercise is? Do I have the ability to communicate and teach him that? Healthy eating? Yep, we're all supposed to eat healthy. That dessert, I ate it. Anyway, there's so many things that all of us in a room are working on beyond what Miguel chooses to put in his mouth that have an impact on what he can choose. Access to fresh fruits and vegetables. Maybe he lives in a food desert. Turns out he does. His understanding of nutrition. I can tell him in the exam room, don't forget to eat a lot of fruits and vegetables. Kale is a great superfood, and Miguel's sitting across from me, even if I have really good interpreters in the room with me, thinking, what is kale, and does my corner store, stock it? And because he has no access to a grocery store. So those are really important things that we need to consider. Medication non-adherence, yep. If I send in a prescription for you, I'm going to tell you take it, it's important. But there's so many things that go into whether or not Miguel is going to take his medicines. Do the pharmacies in your communities have the ability to print out the instructions in whatever language I tell them to? I'll tell you that there's plenty of pharmacies that don't. Even if you write the instructions in the foreign language, they're going to call you up because they can only print it in their computer systems in English. There's the number one barrier. It's actually one of the most common adverse health outcomes in somebody who doesn't have good literacy in English or at all literacy. So maybe Miguel can't access a pharmacy if he doesn't have one in his neighborhood and has no good transportation. There's not good public transportation for him to get there. Our system helps reduce some of those barriers because we dispense medicines on site. So when we're newly diagnosing a patient with a new condition, whether it's an acute sore throat or their diabetes, we have medicines we can start them out on. We also have mail order systems. That's great, but if you have a transient patient population, a mail order system's not going to work. So there's so many things here that we all could be thinking about outside of that healthcare interaction. I just want to spend, Michelle mentioned a lot about the social support and social inclusion, and Miguel is a recent immigrant in the past couple of years, I think, and most of his family remains in El Salvador. He's living with a cousin. And he's not really well connected because he's working so much to make ends meet and send money home. And we know that emotional people that don't have really good support structures, don't have good emotional support, are more likely to report feeling stressed. Stress takes its toll on every organ system in our body. It could be why his diabetes and high blood pressure are so uncontrolled. More likely to report feeling depressed. Depression is a real significant issue for people and being good contributors if it's untreated, unmanaged, and contributing to their communities and being productive members of society. And they're less likely to adopt healthy lifestyle behaviors. So I'm just going to kind of summarize. We ask all our patients in a visit that we have called a comprehensive health review, which is basically 60 minutes to sit down and talk to a healthcare provider about your health, which is a very wonderful gift that employers offer to their employees when they ask for Marathon to operate their health centers. We talk to them about barriers to health. And we usually start off with these very superficial type reasons. And I'm a good public health worker. I did it before I became a doctor. And so I know to just keep asking why. Why don't you have time to cook? Why don't you know what foods are healthy? Why don't you have willpower? And what we learned when we asked Miguel, he walks a mile to work, but he's just strolling. And he has to stop a lot because it's not a safe situation. So it's not truly exercise. So a lot of healthcare places would say, oh, you walk a mile to work, that's great exercise. But when you get down to it with Miguel, it's actually not. He lives in a food desert. He is a few miles from the closest grocery store. And if he can get there to buy that magical kale, he doesn't have a kitchen because his housing situation is subpar. And he's in an inefficiency with his cousin. These are all place-based issues for Miguel and extend beyond that medical interaction that we consider healthcare. So Michelle already showed this, but access to health services, so even if they can come in and see me, I need to deal with all these other things on the screen, and everybody in this room is a partner in that in order to make sure that everybody is healthy, that our communities are healthy. And so Larry's going to talk about some really exciting things he's been part of.
So again, one of the main, to me, it was a profound awakening. And if you leave with one thing today, I hope it's this, that if you're in either directly as a public entity or in a related field, whether it's a university or it's a nonprofit, and you're trying to do work for cities, you're in the healthcare business. Now, you may think about that as a metaphor, but what I'm here to talk about is that in other countries, it's not metaphor, it's literal. And I'm going to talk a little bit about some of the things that we started to do at the City of Rockford to make it a very literal thing, including trying to get funding from systems like Medicare and Medicaid. Most of our efforts that I'll talk about today up till now have been funded through grants. What do we know about grants? They're inconsistent. And if you're in local government, what kills a lot of initiatives, whether it's in violence reduction, trying to reduce opioid abuse and overdoses, if your funding is grant-based and it goes away, you lose credibility. So one of the things I finally started to do in my time in office was literally to meet with managed care organizations like Blue Cross and Aetna. Those managed care organizations that are doing work in every community in the country. But I would be shocked if anybody told me in this room that you had visibility with Blue Cross's managed care organization in your town. I asked the question to folks like Blue Cross and Aetna, what does violence, let's take domestic violence, cost the state Medicaid system? Not that they couldn't figure it out, but they had no idea what I was talking about. Wondered why I would even ask the question. And that's really what I would say, why it's so important today that when you leave here, you think, literally, we're in the healthcare business. Who do I need to talk to start making that a very literal connection? So for us, I started to realize, hey, one of the guys from one insurance company said, well, if we do a partnership with you, you got to be at risk. So we got to spend money, right, according to him, and put it at risk and that we might not get reimbursed. And I said, do you know what business we're in? Our taxpayers are already paying for our police department and fire department. We don't get reimbursed for anything typically in the police department unless it might be a few dollars for a grant. Our fire department only gets reimbursed if we do an ambulance transport, and that's the thing that we oftentimes don't get fully reimbursed for, right? Because we're transporting Medicaid patients. So one of the success stories I'm going to tell you about where we started to really learn about population health was in veterans homelessness. I, along with quite a few other mayors, took the President Obama's lovely wife, Michelle, made a challenge to mayors across the country to end veterans homelessness. I took that pledge in the end of 2014. By December of 2015, the city of Rockford was the first city in the country to reach the functional zero definition of ending veterans homelessness. I would have told you at the start that there was no way we were going to do it. I was reluctant to take the pledge, but I was being pushed by a representative that we had from the White House that was embedded into our city. One of the best programs I ever saw was the Strong Cities, Strong Communities initiative, where we literally had a White House representative in my mayor's office helping us to make connections. He also pushed me to think about place-based health, to think about place-based economic development, and to think about what we could do if we were really willing to take that pledge. So we took the pledge, and I started learning about things like collective impact. I'm just going to go through this definition real quickly. Anybody, by the way, in this room heard of collective impact? So it came out of a Stanford Social Innovation Review article in 2011. I'll read it real quickly. Collective impact is unlike most collaborations. Collective impact initiatives involve a centralized infrastructure, a dedicated staff, and a structured process that leads to a common agenda, shared measurement, continuous communication, and mutually reinforcing activities among all participants. The way I like to summarize it is that it's every sort of collaboration. It's collaboration with accountability built into it. And we literally built a model now in a number of areas, including education partnerships. We have a program called Alignment Rockford in Rockford based on collective impact principles, and we use that to have success with veterans homelessness. So, by the way, anybody familiar with Continuum of Care methodology and language when it comes to homelessness? So if you receive federal money for homelessness, you have to sign on to a lot of requirements. What we required, we already had a continuum of care, right? So essentially we were doing collaboration before. When we did collaboration with collective impact, it involved a number of principles that just happened to also be population health management principles. So one of the things you'll find is that it's payer driven. Whether they're doing population health inside a given employer's place of business, or we're doing it with federally supported payer through a continuum of care, that continuum can drive alignment. And so we use the continuum. If you want to receive money, you had to adopt a housing first strategy. We heard that in one of our other presentations. I can't remember who said it, but that is a really integral part of what we did. So the payer matters. The housing first strategy is similar to having, when you're doing chronic condition management with somebody with diabetes, there's very specific protocol that's put out on what's best practice, what's the standard of care. For us, housing first became that standard of practice that we would measure every one of our patients against, or I'm starting to use the healthcare language. You might call them a customer or a client, but really that's what the practice was, the standard of care on housing first. Most importantly, we created the name by name list. What Michelle talked about that happens in every Marathon Health clinic is that we take all of our claims data, we do risk stratification, we create a list. Once you have a list, I used to think that we wouldn't solve homelessness until we had everybody on the same cloud-based case management system. I was wrong, and I learned it. I was humbled in 2015 when I realized the only technology we needed existed, back when I was in college, called Lotus 123, right? If you remember, way in the very first spreadsheet program that came out, all we had to do was somebody using literally a spreadsheet to have one master list, and everybody in the room, when we do collaborative case management, had to be at those meetings once or twice a month where we go through the list. All HIPAA compliant, very personalized, but de-identified data that we use to drive our work. We would use that to hold each other accountable, and that's what we'd have a case manager from some organization responsible for each individual. We do outreach, intervention, and ultimately risk mitigation. Then ultimately, I would get the reviews. I would sit in from time to time at those management meetings, but most of my work was at the policy level, where once a month I would get a public report on our status. And the ultimate approach is similar. If you're familiar with the Affordable Care Act, ACOs, Accountable Care Organizations, essentially what we created was an accountable community organization where all of us were really part of the same program. I'll tell you, the one weakness in the program is that it was still grant funded. So we were at risk of the program going away if we would lose our grant money. This is just an example. This is Paul Paddock. He's one of the folks I got to meet. He's a veteran, became homeless, great guy. By the way, Paul would freely admit he was still using alcohol at the time when we got him housed. But we found, and I learned this the hard way, housing first was the best chance to give him an opportunity to actually become sober, right, as opposed to living off the streets when he was self-medicating. So we had success in veterans homelessness. I'm going to try to work through the rest of these slides so we have plenty of time for Q&A. But then I asked, well, if we do it for homelessness, what else might we use these collective impact principles and these population health principles to attack? So we started thinking about things like our opioid crisis, job training and job growth. Anybody familiar with Workforce Investment Act, or WIO, the Workforce Innovation and Opportunities Act? A nightmare. I was the chairman of the WIA organization for 12 years. It drove me nuts. But through collective impact principles, we thought we could do better. And the ones that we had some of the most success in education with a program called Alignment Rockford. And the last one, which I'll go into a little detail on, is public safety. So this is I'm about to show you a cartoon, which I think it flatters me nicely. It was published in our newspaper in December of 2008, and I think it says volumes about what was then and probably still is the state of affairs in most communities when it comes to mayors wanting to get involved in other areas of the community where there's other governments who have the responsibility for it. So this is me. You like the likeness? So that's me. They're making fun of me about me wanting to be involved in the public schools. So it's me saying I don't like the way the schools are run. By the way, I didn't appoint the board of our education. They're all independently elected. I don't think our judges are tough enough on criminals. Another commentary about me and the criminal justice system. And then finally, me sitting on Santa's lap with Santa lecturing me, which is essentially a metaphor for the editorial board of the local newspaper. Look, how about you just stick to being mayor and I'll decide who's naughty and nice, right? I don't know if anybody else has had that experience, but I can tell you, very frustrating when your citizens expect you to move mountains and make miracles happen, but this is the treatment you get from the local newspaper, right? Essentially, they're telling me to stay in my lane. fix potholes. Literally, I'd tell me take care of the roads, they'll worry about the other elected officials. Not very fun, nor is it effective. So what we did, and this is an actual chart I made that we submitted with a grant that was funded through the state of Illinois. You get copies of this if you want to look at it in more detail. I'm not going to ask you to think about the detail, just think about a couple principles. We knew to be effective, we needed to involve a lot of different silos. So essentially, and we replicated this now in education and some other areas, created a policy group where I would sit, operations group where I might have a city administrator or a police chief, then all kinds of tactical teams going after various aspects of violent crime. We started off with a prisoner reentry program where we had some effectiveness and a focused deterrence strategy. We looked at domestic violence, juvenile violence, group and gang violence, and child abuse and neglect. And what I can tell you is each one of these things, I no longer think of them as on their own, I think of them as chronic conditions. I'm trying to tell you, you gotta think about health language. If these are chronic conditions and now there's best practices and standards of care to go after this, now we have a methodology to try to hold our team together as we try to move through all of the phases of the criminal justice system to lead to a better outcome. Essentially what we were doing, this is one of the Marathon Health charts that we had that I pulled out, and I realized, Jesus, we're doing the same thing in criminal justice that we were doing to manage our own city employee population. Identify risk, mitigate risk, change utilization, capture savings, right? So this became something that we submitted to a state grant, which was ultimately funded in my last year in office. And the jury's still out on that program. We're moving it forward. I'm going to come back to that in a second, but I want to tell you, along the way, I had a very profound moment when I was working with some researchers at the University of Illinois College of Medicine, who, when I was describing all this stuff, they said to me, well, you're trying to do what they've been doing in Cuba for a long time. After the Soviets pulled out, they had to develop, which was a centralized system, they had to develop a decentralized system that really connected what was going on inside the hospital with what was going on in the community. And for there, they anchor it through a thing called a Polyclinic. About 1,000 patients per doctor. It links national health initiatives to the local community, coordinates community care, and really importantly, from a public health standpoint, they actually have clinical data that rolls up into their national data, national picture of care. So unlike a lot of our census-based data, their data is actually actionable. It ties back to actual clinical records. That's a little bit what Michelle talked about when we roll up as a private company. Our customer experiences at every clinic into a national picture of how our customers are doing. That's essentially what I try to do as a mayor working with our local care systems. This was a former U.S. Senator and medical doctor Bill Frist commentary. In America, doctors wait for our patients to come see us. In Cuba, I'm increasingly convinced that doctors do indeed go to the people, into their homes, build relationships, and intervene before health issues become serious. Who made the comment in the other room? Oh, it was the university president here at Johns Hopkins. It's important to be not just in the city, but of the city. Oftentimes, my experience is you may have a great Medicaid clinic in the neighborhood it needs to be, but their work stops at the doors of the clinic. Might be in the neighborhood, but not of the neighborhood. And that's what they've gotten right in Cuba, where the social workers, the clinical, and the clinical workers work together towards improved outcomes. So essentially, that's a combination of great clinical care plus population health management that's being in the neighborhood and of the neighborhood. And that's, for us at Marathon Health, it's being in the workplace and of the workplace. Now, here's why I'm very hopeful. Despite all of our challenges, the Centers for Medicaid and Medicare started a program, I think it was 2015, maybe a little bit before that, the Accountable Health Communities model, which addresses this critical gap between clinical care and community services in the current health delivery system, testing whether systematically identifying and addressing health-related social needs of Medicare and Medicaid beneficiaries through screening, referral, and community navigation will impact healthcare costs and reduce healthcare utilization. So that's where we get to these emerging models about how to pay for all this stuff and why your work as a city literally should be considered a health work. So this is a letter I got from the Illinois Department of Public Health that same month that we reached our milestone for ending veterans homelessness. we got this letter for the first time authorizing our fire department to do mobile integrated healthcare. Anybody familiar with MIH, mobile integrated health? Really important stuff. If you can get medical, if you're licensed to do mobile integrated health, your firefighters can now give care in a home and not have to transport somebody to the hospital. If you think about cities, you've already spent the money to have trained paramedics. Wouldn't it be great if you could flip a switch one day and all of a sudden they could be community care workers, literally getting paid by Medicaid or Medicare to do work in your community? And I wish I could tell you that I got done while I was in office, but we were working on it, and just after I left office, a couple months ago, we got our first contract with Humana, it's public record, which is paying now our fire department to do house calls, to deal with their patients, which are our citizens, right, Medicaid folks, in their homes where the care is going to be connected, dealing with the social determinants that Dr. Loffredo and Michelle talked about, dealing with those issues that the mayor said are so important to him and all of our communities. So it literally is a fundamental change from reactive to proactive. And we're now at risk, and we're exploring these. So our first pilot contract, we're just getting paid per capita basis for the treatment. But ultimately, we want to go at risk. So when I met with the folks from these managed care organizations, and I asked them, how much does violence cost, let's say domestic violence, our community and cost the state of Illinois? And what if we work together to reduce that? When we go at risk, that means we share in those savings from reducing the costs to the state. And this is another initiative that our state's working on right now. It's not still in progress, but we're now asking for, all these managed care organizations could do a lot of stuff around behavioral health on an experimental basis. They can do pilot programs like we are starting to do. But we're also asking them to, just as a matter of rule, on a lot of other clinic or community-based health initiatives to allow us to submit a bill to Medicaid. And so this Medicaid Section 1115 waiver is something I testified for at the state of Illinois for an application that we submitted to the federal government. We think this should be the norm, not the exception, but right now we've got to ask for the exception so that we can start recovering revenue for a lot of our community-based interventions. So essentially what we're trying to do is connect horizontal service area silos and vertical connections across local, state, regional, and governments. And this is just a real quick sketch I put together describing a comprehensive approach to community health, city-based health, where we're really trying to use our metropolitan planning organization. Anybody does GIS work, anybody works with the metropolitan planning organization, if you're a community region over 50,000 people, you have this asset. Historically, those organizations have not been asked to be in the health business. We started pushing our MPO, as it's called, to be in the health business, which I think is an important model opportunity. For further reading, we've got a number of references here that we can, you feel free to dive into. Any of us would be happy to do Q&A with you after today, whatever we don't have time to. But we wanted to open up here at the end. We've got about 10 minutes to take any questions. We threw a lot at you, but any questions for any of us that we can be helpful with, we'd love to chat about it. Anything? Yes?
Great stuff. Really enjoyed it. So it would appear that if 12% of this is health, then you've pointed out that you need to have all the other players involved: government, business, education, law enforcement, etc. So it would appear if I can choose a 5-block radius of West Baltimore, which is across from university, if I can get all of those folks to buy into this, then I could impact a large population. Do you have any examples of cities, areas that have done that? Obviously, the challenge is getting all those entities to come to the table because they're all concerned about how much am I going to have to pay. But if you had all those together, it would appear that probably not all, that they would pay not a lot from the individual part. So any examples?
Yeah, a couple ones that we've already heard of earlier today. A couple people mentioned the Harlem Children's Zone. Essentially, that's a collective impact, all hands on deck approach. What the mayor of Orlando talked about earlier as well, in that high crime area that he targeted. There's examples all across the country where you see this type of focus starting to take place. The problem that I see is that it is ad hoc, it's scattered as opposed to systemic. But there's a number of great examples. And again, this if you go to the website I had up referencing the Accountable Communities program now through the CMS offices at the federal level, there's all kinds of interesting pilots that essentially, if you want to get funded on this pilot level by the federal government, you've got to offer an opportunity to do exactly what you're describing. You take an area, usually the successful programs are trying to be, that I've read about, are defined, they're specific. Or if you don't want to wait for the federal government to fund you, which I would get very frustrated. So this grant we received from the state of Illinois, sometimes I wish we didn't do it. The reason the grant helped is it got me to get all these different players to sign an agreement to support the grant. The chief judge, the state's attorney, all independently elected officials, right? As well as county health department. The grants sometimes are good to bring people together, but they're also painfully slow at times on execution. That's what my experience has been. Other one I'll mention to you just on the education side where we've had a good amount of success in our community was a program called Mayor of Rockford that was built off of a collective impact operation in Nashville, Tennessee called Alignment Nashville. And now the city of Rockford is part of Alignment USA. I tell you, certainly not perfect. There's things looking back I would have changed or might do differently moving forward. But it beat the heck out of that cartoon that I was dealing with when I was just battling, it was just a matter of political will, battling with the superintendent of schools or the school board president.
Another thing I see a lot that Lincoln Industries is really strong, and I would actually ask if anybody has thoughts on this, but just the public-private partnership of groups of employers. So in Lincoln Industries, there's the Healthy Lincoln, community-based health initiatives, and I know most cities have these. But they're very intentional about getting all the major employers in the same room with some of the community services to affect change. So I assume that's not a unique model, probably more developed in some areas, but I don't know if anybody has examples of where private employers have these business groups on health that are at least impacting some of these health initiatives and priorities for communities. Does anybody know of other examples like that? Or involved in a business community on health?
We have a labor management health fund that actually works with several businesses and the county and the city and the local police departments.
Yeah.
So
They do a lot.
one of the
They do a
things
lot.
that,
They do a lot what
Go
they
ahead.
do. They do a lot of things that you do.
And it's usually targeted,
Okay.
usually targeted at a few pre-identified priorities. So there's usually, maybe it's from the county health rankings or whatever, some areas that they feel are priorities. It's often access to mental health or a few other things. And these private employers, when they get together, can have significant impact in a community.
What we do, the county is self-insured.
Right.
So with labor management health organization, we actually invite them to our meetings every year to see where we spend our healthcare, what the highest costs were. So we reprioritize every year. And labor health management does it with all the different organizations. But they share a lot of that data with us as a health department, what they're getting from other employers so that, we kind of include that in our community health assessment.
so one of the things we're planning to launch next year with our Marathon Health public sector customers. So part of my job is government relations. I'm also involved in government new opportunities, sales. But with our existing customers, I've been flying around the country meeting with them. We'll be launching next year a cohort of our public sector customers who will be sharing data with each other on actually very specific population health data. So the data that Michelle referenced earlier today, we keep that as our internal book of business. How are we doing from a customer service standpoint? It's how we hold ourselves accountable. But what we really find, and frankly, this is something I wanted, I was a customer before I was an employee of Marathon.
Right.
And what I said is, hey, I want to know if there's a best practice that is going on in Plantation, Florida, happens to be one of Marathon's customers, that I can learn from there, that they're doing something right. I want to have a format, a platform, if you will, where we can share those best practices. This gets to this point where I really believe that cities need to be owning health like we've owned other challenges. And we can't very effectively, in my opinion, talk about wanting to reduce violence if we're not talking about addressing violence as a health issue and literally getting funding. Every mayor that I talk to wants more money for cops, right? Well, what if you can get reimbursed because by insurance for prevention-based interventions, because your police officer was trained to do an evidence-based screening, intervention, and referral to treatment. So that's what we're looking at in Rockford. Those are the types of proposals that we're moving forward to. Again, evidence-based work with best practices that are in place, but it's a way to literally bring revenue into your organization. I would love to tell you that we've been doing it for 10 years and it's solved. It's not. This is a workshop, right? So we're talking together, how can we start advocating as a collection of local governments to drive this? Otherwise, who owns health? Hospitals, the supply side, right? We represent the demand side. And just think about this. If you have a food desert, who pays for a lot of food in this country? The federal government. It's called food stamps, right? They pay for health care. What if you started to create literally your own local currency, trying to make it cheaper to buy food, potentially good food, but also saying, hey, we got a lot of demand. We want you to put a grocery store in this market, right?
That's what our health department is into. A lot of things we actually oversee with Food Policy Council, which addresses things like food access, and we're trying, and also we talk to physicians about prescribing food.
Right.
Food
Absolutely.
medicine,
Yeah.
because it's just,
Right.
so we're really doing a lot of the things that you're talking
Awesome.
about.
That's another example of what businesses can do too.
Right.
Is to say, we're trying to, our cafeteria is all stocked with healthy food, but the whole way home that our employees take is all
Oh, you see
lined with
fast-
fast foods.
That's right.
And they can actually apply some pressure or make it attractive for businesses to come in and have a healthy
Well, true,
healthy
but
option.
And the thing with food access, though, is you can supply the healthy food, but that doesn't mean people are going to eat it. And that's one of the things that we've come up against is, we've had healthy corner store initiatives and bringing healthy food in, and community gardens, but if people don't know how to use the food, or they don't, it doesn't look appetizing, they're not going to do it.
So anybody doing community kitchens where they're teaching folks how to cook?
That's one of the things we're trying to do. We got to make it look great.
Yeah, there's a couple of, actually one of our public sector customers who has a Marathon Health Center is actually about to release an RFI where they're trying to solicit partners who will build a community kitchen essentially. I know that customer well because that's where I used to be mayor, right? So
It's not building the kitchens, you might want to look at the churches, because they already have.
right. So Detroit, I was just going to say that you just reminded me up in Detroit, I know they have a network of community kitchens who makes those types of things available. Yes?
I'm piggyback on that, and what we're doing is, we started a Capital City Farm, so
Where
we
you
took Trent, New Jersey.
Right.
So we took what was a brownfields, of course, cleaned it to, the standards necessary in order to grow. But we have 2 acres, and it sits right next to our soup kitchen. Our soup kitchen is not open in the evenings or the weekends, and so what is grown on the farm, then we utilize the soup kitchen, a partnership with the soup kitchen in order to utilize their kitchen to teach classes, to show how to prepare some of these foods that are grown on the farm. So to your point about utilizing some of the kitchens that are already permitted
Right.
to serve as community kit or commercial kitchens would allow you to be able to do that, as opposed to trying to build those community
Yep.
kitchens.
And to get the people in, you need to hit up the block clubs and stuff like that. You have to use the community people
So-
to bring the community in.
So one of the things we talk about with our customers all the time is engagement. And it was just interesting when I joined Marathon Health and, I heard all the emphasis on it. And, we have success when people come into our centers. They don't come into the center, it's like a homeless person who you get upset that doesn't come to your office, well, you gotta go to them then, right? So if we're not successful bringing someone in and they're still on our list, then what do we do to go out to them? So it's interesting to just hear the different methodologies that are being used. We heard that from some of the mayors last night and today, different strategies to work with or bringing in, Mayor Brown talked about bringing bringing a bunch of gang members, right, into a gymnasium, having a conversation with them about violence. Different way of doing it, but you gotta getting in the middle of it. So I just found out, by the way, a few more minutes. I thought we had to be done by 3, and they just gave us a little bit of reprieve, I guess, since we started a little bit late. But yeah, go ahead.
Hi, my name is Natan. I'm with Cure Violence. So I have to say it's extremely encouraging to hear you all including violence in what you're talking about, and to hear you say the words violence is a health issue, right, is music to my ears, because that's exactly what we work on especially with our participation in staffing the movement towards violence as a health issue. So definitely a piece of that is looking at how workers who are doing, the frontline work of intervention and prevention in terms of violence, when viewed in a health, lens, really they're doing health work, right? And so they're doing the primary prevention in that sense. So actually doing the policy work to get them eligible for reimbursement for that work. And Dr. Cooper, I know that is super involved in that work, but it's great to hear you talking about that, and I'd love to hear more about how that can transition, because I heard you talking about how police officers could maybe get classified that way, firefighters, but I think that there's extra hurdles, especially with insurance, to get these frontline workers, similar to fights that are happening around community health workers, to get them classified, to standardize training in that sense, to actually have them be able to be reimbursed for the work that they're doing.
So you just reminded me of all these frustrating meetings I had with Medicaid managed care organizations. So the truth is, at least in our state, they have had a lot of flexibility to do innovative reimbursement pilots. They've just not had a lot of meetings with mayors. I think I was the only mayor that's ever reached out to them with my fire chief, with my police chief, with our head of our human services organization, said we want to chat about getting paid to be part of essentially an ACO. So I wish I could tell you I was the expert on how to get a program certified. I'm not, but I can tell you we started making progress just by having the conversations. And I also could tell you, I was having this conversation last night with someone. Looking back, I had an insurance consultant that we work with who was a great friend, still is, really educated me a lot about the basics of population health. And he's the guy who said, create an office of population health in the mayor's office. So looking back, I didn't do it. I wish I did. Now I'm telling all these mayors, give somebody the title in your office of the director of population health, and then give them permission to work with an expert, not probably from the insurance company, not that they're bad, but they're on the other side of the negotiation. Find a broker, find a consultant, find a university professor who's an expert in insurance, and then start literally talking about the nuts and bolts of what a reimbursement agreement might be. You're essentially going to be part of a managed care organization. That's something cities historically have not done. That's what been the healthcare world. That's what hospital executives have done. My whole thing is, again, looking back after 12 years, I should have been doing, I wish I had known that in my first term. I didn't. I thought about cities in a traditional lens. This conversation, I think we're just getting started, but this is what, like I said, countries like Cuba have been doing this much more integrated approach. Most of the world, because it's a single payer system, has been doing this a long time. But simply because we're not single payer, you get a lot of, the way I look at it is you have a lot of single payers. They're called self-insured employers. Who's another single payer? Medicaid, Medicare. You start adding up all of your private employers who are self-insured, Medicaid and Medicare, and all of a sudden, if we could start going in the same direction, we could dramatically impact service delivery and the healthcare ecosystems in our community. I just think as mayors, county executives, school superintendents, we've been too passive, and we need to be more active. Other thoughts? We got a few more minutes. Questions? You think we're crazy? Hey, if we weren't partly crazy, we wouldn't be here, right? Because we're wanting to change the status quo, so I think anybody who wants to do that's got to be a little bit crazy.
Well, we're happy to stick around if anyone has questions afterwards, too.
Yeah, absolutely. I want to thank Mayor Irvin for being here and participating last night and today. Thank you for your work in the city of Aurora. We're neighbors with each other, so I'm sure we'll be seeing each other again soon, hopefully. But again, anything we can do to help explore options for your organizations, your communities, I'd be glad to help. Thank you very much.